Okay, good evening, everyone, and welcome to the second webinar in our neonatal-themed week here at Mind the Bleep. It's my pleasure to be joined by Dr. Phoebe Johnstone, who is an SHO that has worked on a neonatal intensive care unit and is here this evening to teach us all about the NIPE. So over to you, Dr. Johnstone.
Thank you, James, and welcome everyone joining today. As James said, my name is Phoebe. I'm an SHO living in Manchester and working in East Lancashire. And I'm here to talk to you today about the NIPE, or the neonatal exam that happens in the first 72 hours. So today is going to be a bit of a jack of all trades, covering what the NIPE is, having a bit of a chat about why and when it happens, and then we're going to run through the NIPE examination and questions, what some of the results may mean if you find any abnormalities, and what are the next steps after you've completed the NIPE going forward. So the NIPE is a nationalised programme, so it happens all over the country, and it involves an examination of all neonates within the first 72 hours of life. There are some exceptions to this when their babies are particularly preterm or if they're unwell and admitted to NICU. But generally, the aim is to have this happen to all babies within the first 72 hours. And the aim of it is to effectively detect any children who are born with congenital abnormalities in 4 main areas. And these areas are the eyes, the hips, the heart, and the testes in male babies. And effectively, it's just to try and reduce morbidity and mortality long term by doing this screening to everyone. Following the first NIPE that happens within 72 hours, there is a repeat examination that happens by the GP within the first 6 to 8 weeks. And this is effectively like a second safety net to ensure that nothing is missed, and that as babies develop and things become more apparent, they are picked up in primary care. So before you go into the NIPE examination, it's really important, first of all, to make sure that you've had a chat with mum and dad, and that you've had a look through mum's notes. And these are the notes from the antenatal, from prior to that, if their mum's got any long-term health conditions, if there's been anything that's been picked up on ultrasound antenatally in any of the scans, and if mum's had any particular screening. And then it's really important to go through some questions with mum and dad, and these are to pick up risk factors prior to going into the examination. So the main and important screening questions involve asking if there's any risk factors for baby having DDH, or developmental dysphagia of the hip. So this involves whether baby was breech at any stage of the pregnancy, if the baby was a twin, if the other twin was breech at any point, if there's any first degree relatives with DDH. So these are either mum's parents or dad's parents. And if you have any risk factors there, regardless of your examination findings, it's important to book an ultrasound of the hips for the baby. And this occurs at 6 weeks. And this is just to make sure that any babies who have these risk factors are safety netted and examined, even if you can't find anything abnormal when you examine them. It's also important to ask screening questions about whether there's any family history of any congenital eye conditions or eye conditions in the birth, any congenital heart issues, or any issues with the kidneys. And these are just the screening questions that you ask mum and dad before proceeding into the examination. Now, going forward, it's really important that when you're examining baby, obviously you are somewhere that you can keep baby warm, because you're going to be making sure that you see every aspect. You want to completely undress the baby. You want to have a look at all of the skin. And so the best plan is to be either as a heated incubator or a resuscitator so that you have warmth there. Also, you can explain to mum and dad what you're about to do. Make sure that they're in the room in case the baby gets agitated. And there's some parts of the examination that is really helpful, having an extra pair of hands there, especially if the baby gets a little bit agitated at any point. So as with all examinations of a patient, the most important thing to do at the beginning is just to have a step back and have a look at the baby in general. So you're just having a look for baby skin tone, having a look for the pallor of the baby. Like if there's some pallor, it could indicate that there's poor perfusion. It could indicate that there's been like a hemorrhage elsewhere, intestinal hemorrhage, or some kind of big bruising event after birth. You want to have a look to see if there's any evidence that baby's jaundiced. So have a little look at the sclera, have a look at the skin tone. And there's going to be another presentation this week all about neonatal jaundice. But does anyone who's watching have any idea what the risk of a baby with jaundice that doesn't get treated, what the jaundice can develop into? Just pop it in the chat if anyone's got any idea. Well, as I said, we'll go into it a bit deeper in the presentation, which I think is tomorrow. There we go. Yeah, connectorus. Brilliant. That is correct. And this is effectively something that we're really worried about and we really want to avoid happening and can cause long-term brain damage for babies. But as I said, we'll go into that a bit deeper later on in the week. You also then will just have a look at baby's tone, how they're lying in the bed, if when you've been observing baby with mum, there's been any head lag. This is something that you want to keep an eye on because babies who are hypertonic will have difficulty feeding and could be a sign of something like an underlying sepsis or an underlying metabolic or neurological condition. Next, we move on to having a look at baby's head. So you want to have a look at the head, look to make sure if it's got a strange size or a strange shape. So microcephaly is a small head. So that's when baby's head is abnormally small compared to what it should be. And macrocephaly is when baby's head's a bit larger. And macrocephaly can be a sign of hydrocephalus. So when there's like the ventricles in the brain are filled with too much fluid. It can also be a sign that there's genetic abnormalities. And you want to correlate the size of the baby's head with the size of baby's body. AKA, is it symmetrical? Is the head small and the body small? Or is it asymmetrical when the head is particularly small and the body's a normal size? And this would warrant further investigation. You want to have a look at the shape of the head. And have a feel for the baby sutures and for the fontanelles, which are the parts where the plates of baby's skull haven't quite fused, and you've got these soft patches, one at the front of baby's head and one at the back. And you can have a feel at these fontanelles. If they give you quite a good sign of baby's hydration status. In a baby who's quite dehydrated, you can note that the fontanelles are really quite sunken, whereas in a baby who has raised intracranial pressure, you might see that the fontanelles are quite bulging. You also want to make sure that you can feel the sutures because there's some conditions such as something called craniosynostosis where the sutures of the plates are fused too early, and these can fuse in different places, and this needs onward referral as it would need surgical intervention in order to allow babies brain to grow and there to be space for that. You also want to keep an eye out for any birth injuries that can happen to the skull. And there's, as you can see in the little diagram I've got here, there's a couple of different ones. Caput secundum, which is a really common one, and it's just a diffuse subcutaneous collection. And the thing to note about a caput secundum is it crosses the suture line. So it's because it's just subcutaneous, it can like spread across the whole head. And these are, as I said, really common, often following a ventouse delivery or a kiwi delivery, and they tend to settle by themselves. A cathal hematoma is similarly a hematoma, but this one does not cross the suture lines. And this one is something to be aware of, because in babies with big cathal hematomas, it can lead to onward jaundice. It's effectively just a big hematoma or a bruise that breaks down, and then can lead to, like, as the hemoglobin gets broken down, can lead to jaundice again. And then the one which is quite rare but is something to be aware of is a subgaleal hemorrhage. And this is something that I've never seen that is really uncommon, which is a hemorrhage between the scalp and the periosteum, so the bone. And it's rare, but it is quite life-threatening. So if ever you suspect it, the thing to do is just to get a senior review there. Next, we move down and have a look at baby's face. So you want to make a mark of any birthmarks, any bruises, any lacerations, such as a laceration from forceps. Often you find that in a baby that's had a forceps delivery, they have a distinct line or an out, like a, sometimes even a little cut from where the forceps were when they were pulled out the womb. And really important to make a note of all of this, because especially when the baby goes home and they get home visited by the midwife, if you've not specifically noted that there was a bruise on the left cheek, or that there was a small laceration, or that you noted a birthmark, the midwife might go home and be concerned and report it as a safeguarding issue, thinking that it could be a non-accidental injury to the baby. So yeah, as I said, really important to make a note of that. And these three pictures that you can see from left to right are just an evidence of different types of birthmarks that you might pick up. On the left is something called a salmon patch. The middle one is a port wine stain, and the right is a hemangioma. And they're all reasonably common and something just, again, to make note of. You also want to keep an eye, have a look at the face, just again, a brief examination. Note if there's any dysmorphic features, so low set ears, like almond eyes, and anything that you would consider to be suggestive of Down syndrome. And at the level that you will be doing the NIPEs, anything that you have any concern about, the thing to do is just to get a senior review. And it's better to be safe than sorry. The ears as well, have a look at the ears, have to check to see that they've got all the cartilage that you would expect. Sometimes you can note little ear tags or accessory auricles. And again, this is something just let your senior have a note of, and they can be referred onwards to ENT and to plastics as appropriate. Next, it's really important to have an examination of the mouth and the palate, both the hard and the soft palate. And when you're examining the mouth and the palate, it's really important not only to look right to the back of baby's mouth, but to also have a feel, because often you can't see everything. So you want to run your finger along the top of baby's mouth, have a feel for any cleft. And it's really important to pick these up, especially because they can have an impact on baby's feeding and baby's latching. So these are things that we refer and we try and get sorted urgently. And actually that's something that you want to reassure mum and make sure that you're keeping an eye on. You also want to have a look to the back of the mouth, have a look at the uvula, check to see if there's, you can get things where you have something called a bifid uvula, which is where the uvula looks like a little upside down heart, and just keep an eye on that. And you also want to check whilst you're here, two of baby's primitive reflexes. So one of these is the gag reflex, and you've got to explain to the parents before you do this that you're going to make the baby gag. And you just, with a tongue depressor, just push lightly to the back of baby's mouth, and they won't like it, but it's something to make sure that they have. And also, just as you're feeling along the top of baby's mouth, just allow them to have a suck of your finger, because it's quite a good identification of how babies will latch and whether they'll feed well if they have a good suck reflex and have a strong suck on your finger. Again, if you note that like a baby's suck reflex is weak, or that they don't seem to be rooting and latching for your finger, it's an idea to take a step back, because sometimes these really non-specific findings can be a sign of an infection in a baby. And again, there's a presentation later on in the week that's going into neonatal sepsis and some of the signs to look out for. But just be aware of it, because a drowsy baby who's struggling to suck or who's not really rooting around is something just to keep an eye out of, and they may actually have an underlying sepsis. So next we move down to have a look at baby's upper lips, and you want to check, when you're doing these examinations, it's really important to check the symmetry. So you want to make sure that the kind of tone and the muscle mass is symmetrical. You want to have a look for any extra digits, a little extra nubbin or a finger. This is something that I've come across, and they look kind of cute at the time, but also really important to pick up and to reassure parents, because for a mom and a dad having a baby with 6 fingers on one hand, that's the kind of thing that's going to really make them anxious. They're really concerned about onward referrals, about trying to get it chopped off. And sometimes it's not something that gets sorted until the child is 3 or 4 years old. Sometimes it's something that gets sorted much earlier. And polydactyly, or having an extra digit on the hand, can range from something just being a little skin nubbin, or can involve a whole structure of normal tissues, including bones, muscles, blood vessels, and nerves. And in that kind of case, it would definitely need an onward referral to plastics, because it's more than just you chop it off and you're fine there. So you'll probably need to get some imaging of the hand, have a look to see whether there's any neurovascularity to the extra digit, and go from there. You also want to have a look at baby's hands, especially if you're concerned that you think that baby's dysmorphic at all. Have a look for the palmar crease. Does anyone know in what condition you might have only one palmar crease as opposed to the 2 palmar creases that we all generally have? Yeah, brilliant. There you go, Down syndrome. So a single palmar crease is another thing that you would want to make a note of, and going forward can be a sign of this trisomy. Now, next we move down. Once you've done the upper limbs, we move on to the thorax and the abdomen. And I'm not going to go too deeply into a full examination of the chest and the abdo. Again, it's something that's going to get covered a bit better in the sepsis PowerPoint. But you want to have a look at baby. You want to see what the work of breathing is. Have a look to see if baby's got any intercostal recession, if they're working hard, if they're noisy breathing. You want to have a look to see when they're breathing, does it look symmetrical? What's their respiratory rate? Does anyone know what the normal respiratory rate in a baby, in a neonate is? This is a bit of a tough question, but a clue is it's definitely a lot more than we look in an adult. Over triple, quadruple what we expect in an adult. Yeah, brilliant. It's between 30 and 60, about is what you'd look for. You want to have a listen to the heart as well. Have a listen for the heart rate. Babies neonates tend to have a heart rate of about 100 to 160 beats per minute, and have a listen for any murmurs. If you do hear any murmur, it's really important that, again, you get a senior review. Often systolic murmurs in the first 48 hours are not abnormal, and we just keep an eye on things, listen repeatedly over a couple of days to see what goes on. But if you have any concerns, like baby's colour or anything is not what you would expect if they're a bit cyanosed, then it's definitely something that you would need further investigation of. But effectively, at your level, if you hear anything that you're concerned about that doesn't sound just like a normal lub-dub heart sound, get a senior review of that. You also just want to have a little feel of baby's tummy. Is it soft? Is it extended? Can you feel any organomegaly, like particularly, can you feel the spleen particularly, or the liver? And just have a listen for bowel sounds as well. So next, and this is a really important one, and something that I really struggled with for the first few NIPEs that I did, even though you think it's going to be something that's really, really quite easy. It's just to have a feel for the femoral pulses in a baby. And it's really important because in you or I, or when you're examining an adult, we have lots of pulse points that you can feel, the radial pulse, the brachial pulse, but in babies, they're pretty unreliable and often you can't feel them there. So you want to have a feel for both femoral pulses on either side. And it's important to be really patient here. Sometimes you press a bit harder and then you can't feel them because you're almost occluding the vessels, but you want to feel lightly in the creases of both legs. Be patient and have a feel. And you really need to be able to feel the pulse on both sides. And if you can't, and if you've listened for about 3 minutes, felt for 3 or so minutes and you haven't been able to find anything, then really important to, again, just get a senior to come and have a feel. Sometimes it's one of those things that you're trying too hard and then you get yourself worked up and you can't find it. And I've had that a million times. But this is something that in a sign when you have weak or absent femoral pulses, it could be a sign of some kind of congenital cardiac abnormality. And so it's important to correlate it with the baby's oxygen saturation, with the baby's color. And again, it might mean that the baby needs some further investigations, whether that's with an echo or something else. Moving down, then we move on to having a look at the genitalia, and obviously this will be different for males and females. And as I said at the beginning of the presentation, one of the reasons that we screen in the NIPE is to check that in men that you've got both testes and they are descended. So in men or boys, baby boys, you want to have a look to see where the urethral meatus is. You want to have a look to see if there's any hypospadias or exspadias where the urethral meatus is not at the tip of the penis, but somewhere along the length of it. You want to have a feel for both testes. And again, this is something, make sure you explain to mum and dad what it is that you're doing and at the time that you're doing it, and have a feel. And sometimes the testes can be quite retractile where they pull themselves back in. So it can be a bit difficult, again, to try and work out whether you can feel the testes. But again, be patient. Sometimes you have to examine one at a time. And unilateral undescended testicle can be reasonably common, and it's something that you flag up and you will need to follow up later at a later date. But if you can find neither testicle, if you have bilateral undescended testes, that is something that definitely needs to be investigated and could be a sign of a metabolic condition. Similarly, when you're examining the female genitalia, you want to have a look, check that the labia aren't fused, check that you don't have any clitoromegaly, the clitoris is a normal size. And again, if you have any concerns or there's any abnormalities there, again, it might be a sign of a metabolic issue. Next, and this is something that was really hammered into me on my time in the NICU, is to check the anus. And it's something that actually in the NICU that I was working in, a baby had been sent home and it had been thought that the anus had been identified, but actually it had just been a fistula, and turned out that baby had an imperforate anus and that its colon wasn't completely developed, and it was very much a never ever event. So you want to have a look. Sometimes it's easier if you roll baby onto their front, making sure that they're comfortable and their head's to the side. Have a look to make sure there's a sphincter around the anus, and make sure that it's a normal position, that it's not too close to the genitalia, not too far away, that there's no other fistulas that you can see. And it's really important that all babies pass meconium within the first 24 hours. And that's kind of the very dark greeny black, like kind of poo that babies pass. And that shows you that the digestive tract seems to be all working. Abnormal and embryological development can result in what I was talking about earlier, which is an imperforate anus. And this is when the anal canal can be missing or it's closed off, such as you can see in the diagram there. And it can be associated with lots of other abnormalities as part of a syndrome, or it can be isolated. So if you have any concerns at all, it's something to flag up, and it's very, very important that you make sure that you have seen the anus. Next, we move on to the hips. And as we were talking about earlier with the screening, so even if you have gone through the screening questions and you've noted that this baby has risk factors for developmental dysplasia of the hip, you want to make sure that you do this test. And so there's two tests. One is called the Barlow's test, which you'll do to all babies. And this is, as you can see in the diagram, it checks for posterior dislocation of the hip. So you stand at the end of the couch with the baby on its back. So you're effectively at the bottom, and you stand with holding the knees. You flex the baby's hip and you hold the knees so that your first finger and second finger are on the lateral edge of baby's thigh, running down to the greater trochanter. Your thumb is on the medial part of baby's thigh bilaterally, and you push down and then push out and apply a little bit of pressure. And before you do this, you explain to mum and dad what you're doing, you're testing to see if the hips dislocate, and you're feeling for a pop. And this will be the sign that the hip is dislocatable. And I've personally never actually had a baby who's been positive for Barlow's test. I've had babies that I've found that their hips are a bit clicky, but I've been reassured by multiple consultants that having clicky hips and feeling this pop are very different. And once you've felt it, you will know it. If you think you have felt this pop, then you move on to ortolanis, and this is a test to check that the hip has actually dislocated posteriorly. And so you abduct the legs and you feel a clunk, which would be the hips moving back into place. So you only do ortolanis if you have a positive Barlow's test effectively. And if you note that you have this, it's an instant referral. And I know in my hospital that there was a separate referral pathway for babies with positive Barlow's and ortolanis tests compared to those who you've just screened and found that they're positive, like risk factor wise. You then roll baby onto their front, and you want to have a look all the way down baby's back. As I said, it's really important in the NIPE that you have a look at every aspect of the baby. You do not want to be missing anything. You do not want to have not seen a part of the skin where there's a bruise or there's a lesion or a nevi. And you're looking at the baby's back for any signs of any scoliosis. This diagram at the top, you can see a hair tuft and sacral pits, and then on the far right, that is what you would see in a full-blown spina bifida, which you would be unlikely to see on the NIPE because it's probably been picked up antenatally. But just be aware that you can see neural tube defects that present as sacral pits or hair tufts in the baby's back. So anything that you think is a bit abnormal, if you notice a little patch of hair, you notice a lump or a bump or any opening in the lower part of baby's back, again, just get your reg or your consultant to have a look over it. And another thing that is really important, and this is more common in Asian babies with darker skin, is to have a look for a Mongolian blue spot or slate grey nevi. And this looks like a big bruise at the base of baby's coccyx. And as I was talking about earlier, that it's really important to make a note of these. It can really look like a bruise. And if you send home a baby and you've not noted that they have this Mongolian blue spot, and then the midwife goes and does a baby check the couple of days after the baby's been sent home and sees it, they're going to think that this is some kind of non-accidental injury, and they are going to raise it as a safeguarding event. So really, really important to not cause distress to mum or dad and to make sure that babies are safe is make sure you note this. And these tend to just disappear by themselves over time. Sometimes they can be quite extensive, quite large. Sometimes they can be smaller and quite dark, but just keep an eye out for it. Now, what I like to save the red reflex for the end of the examination, because it can be something that you need mum or dad to come and give you a hand with, because babies, they love to open their eyes and have a look around when you don't want them to. And then as soon as you want to go and have a look in their eyes, they screw them shut. So you want mum or dad to stay at the head end of baby and hold the head still. And you're going to explain that you need to have a look in each of baby's eyes, and you're going to have a look with your fundoscope. So you make sure that you've got the light of the fundoscope on, and you want to be having a look in the pupils, in both sides of the pupils, and making sure that you can see the red reflex. And the red reflex is something that we all have. It's similar to when you take a picture with a flash on, a camera flash, and everyone has red eyes and looks a bit scary. But an absent reflex is something that needs an urgent onward referral. So it can be a sign of a congenital cataract, which is the most commonly picked up thing that we see in neonates. It could be a sign of a retinal detachment or a vitreous hemorrhage. And in less so in neonates that are 72 hours old, but in a slightly older child or baby, it could be a sign of a retinoblastoma. So this is something that you really, really do need to have a look in, and make sure that both sides you can see that you have that reflex present. Again, something that I like to say for the end of my examination is check the baby's saturations. And this, you get these special little saturation monitors for babies that you wrap around the wrist and the leg, and you want to check the pre-ductal and post-ductal saturations. And what I mean by the duct that I'm talking about is the ductus arteriosus that is open whilst baby is in the womb, and it tends to close within the first 48 hours. And it's a little communication between the aorta and the pulmonary artery, as you can see in my little diagram here. And what it allows is the mixing of oxygenated and unoxygenated blood in whilst baby's in the womb, whilst they're connected to the placenta and getting their blood supply that way. But it tends to close in healthy babies within the first 48 hours. So you find that when you're talking about a preductal saturation, this is coming from the first vessels that leave the aorta. So it will be relevant to the right arm. So you check the right arm for oxygen saturations, and then you check the postductal saturations, and this can be the left arm or either leg. And you want to make sure that you check both of these, and that both of these should be above 95% oxygen saturations. And you want to make sure that there's less than a 3% discrepancy. And the reason that we're so concerned about checking the pre and the post-ductal saturations in a baby is because abnormalities in this and a big discrepancy, or you're struggling to find it, or they're below 95%, could be a sign, again, of a congenital heart defect. And so it's something you want to correlate again with the femoral pulses. Yeah, exactly. That's what you're looking for. So transposition of the great arteries is exactly the reason why we do pre and post ductal saturations. And again, it's really rare to find this discrepancy and to pick up TGA, especially in a baby who's not been diagnosed antenatally. But it's the thing that you want to make sure that you don't miss. So yeah. And then finally, we move on to just the last bits to tie up the whole examination. And these are just the primitive reflex. We spoke about earlier about the sucking reflex and the rooting reflex, which I find is quite useful to check at the beginning, or just seeing that the question, can it be common for first NIPE to have different preductal and postductal oxygen? So you find that you might have a discrepancy of 1 or 2%, but generally you do not want to have a discrepancy of more than that. As I said, anything more than 3%, even within the first 48 hours, is something that you want to flag up and be investigated. Generally, you find that the pre-ductal saturations are slightly more, so like they can be up to 99, 100%, and often post-ductals are 98, 99%, but they shouldn't be more of a difference than that. So even though the duct is still open, you want to just make sure that you're not missing that. But yeah, back to the reflexes, you want to check the palmar grasp. So this is when you pop your fingers in both the baby's hands, and they should be able to grab on bilaterally to your hands. And you also want to check the Moro reflex. And this is something that, again, you really want to make sure that you've explained to mum and dad what you're about to do, because it can look like you are about to drop their baby, but you make sure you have one hand behind baby's back and you have one hand supporting baby's head. And then you effectively do a controlled, sudden movement where you effectively release baby's head and drop baby down very quickly. And what baby tends to do is spring out both of their arms and move their head. And it's a sign that it's called the startle reflex. So you're basically trying to startle baby, and they should fling out their hands. And it should be, when you're looking at it, you want them to fling out their hands both sides equally. You want to make sure there's no asymmetry there, because again, if there is any symmetrical abnormalities there, it could be a sign that maybe there was a birth injury, maybe there's been a brachial plexus injury. If like baby was born, there was any risk of shoulder dystocia. You want to make sure that there's no hypotonia there. And again, in babies who they don't have this reflex, or they're a bit sluggish in the reflex, it might be a sign that the babies are unwell. Maybe they're septic, maybe they're a bit drowsy because they're jaundiced. So it's something that you'd want to have a look at with the rest of your findings. So after you have finished the NIPE, you want to explain any abnormal results that you found to parents, and you want to explain to them if you have found anything that you're concerned about or that you want to see in your review. Make sure that you say to parents, you're like, thank you for letting me do this. I have noted that I wasn't able to fully get the red reflex in both eyes. Just to make sure that I'm not missing anything, I'm going to get one of my seniors to come and have a look over, if that's okay. And mum and dad are generally obviously really amenable to that, and just try and be reassuring where you can. And if the baby has passed with flying colours, then you can explain to them that it was just a screening examination, but never say to them, oh, your baby's perfect or there's nothing wrong, because it's just a screening, but just say that you didn't find any abnormalities during the NIPE, but that there will be a subsequent examination that happens at about 6 to 8 weeks by their GP or within their like primary care, and then going forward from that, they will be then like checked up further or followed up with any scans or anything. Like, if, as I said, like if you have noticed that they've got any risk factors for developmental dysplasia of the hip, you might then explain that they're going to have an ultrasound at about 6 to 8 weeks, just to have a look to see if there's any risk of the baby having dislocatable hips. And there are my references. And yeah, thank you very much, everyone, for having a listen to me. Does anyone have any questions or anything that I can help with at all?
Well, thank you very much. I'll just give everyone a couple of minutes if they do want to ask any questions, although that was a very comprehensive run through of the NIPE exam. By the end of your placement, were you able to do that from memory, or did they have kind of a nice...
So the first couple of times that I did it, it was really difficult to remember everything, because obviously there's a lot to go through. But by the end, you get into such a routine, and it's why I've gone through it quite systematically here, kind of top to toe, and then round to the back. You actually do find that you run through it really easily, really quickly. It makes a lot of sense. And also, once you note the big things that you don't want to miss, it becomes quite natural. I'm not 100% sure about the 6 to 8 NIPE. I've just seen Kira's question. I never had to perform one of those myself because they happened in primary care, James. I'm not sure whether you're able to give more information on that? Whether it's the same as the
I've got to say it's a little while since I've done one, but I do think it covers most of the same areas. I think it might just be slightly more brief, but perhaps just check kind of what they're doing in your local area.
Yeah. And with regards to a cardiology referral, so it's generally not something that, well, personally, I found that it was never something that I had to do as the SHO. If ever I was concerned about a baby's saturations or about a baby's femorals, I'd get my registrar to come and review. And then following that, what would tend to happen is we'd make sure that you've got the baby on some cardiac monitoring, you'd get an echocardiogram of the baby. And then if there were any abnormalities there found, or if antenatally there'd been any concerns about any cardiac issues, then it would be a case of probably a reg to reg or consultant discussion with a cardiology centre or with like an oral cardiology referral. It was not something that I ever did myself. It was something that I always escalated that there were concerns, and then the investigations happened following further investigations that were done within the NICU unit itself. And tone-wise, it's something that is quite subjective to you. What I tended to do is it would be something that you observe the baby with their mum. You observe to have a look to see, is the baby able to hold itself? Is it moving its arms and legs like the same both sides? Often when you're checking the palmar grasp reflex, you can allow the baby to hold onto your hand, have a feel of both arms, check the muscle bulk both sides. You'd want to check to see if there's any head lag. So you do this by when you pick up the baby by the baby's torso. Is the baby able, like how long does it take for the baby to pull the head up alongside the body? And obviously there will be a little bit of a head lag in all babies, but you don't expect the baby's head to be lolling back completely. But the most important thing is just to make sure that whatever you're seeing, that you're checking it symmetrically, so it's not just one-sided, especially with arms. I mentioned the brachial plexus injuries that can happen in like a shoulder dissociate birth or in like a traumatic birth. And that's, you'd find that one arm is significantly has altered tone or reduced tone compared to the other. And so it's just a case of, as you examine more babies, you get used to it. Anything else?
Okay, I think that might be it for questions, but thank you very much for the presentation, but also the really helpful answers and explanations there. I've just popped into the chat a link to the feedback form. Please do take a few minutes just to give us some feedback. As I always say, we do read these and we do look at how we can improve things, but also all of our speakers, are giving up quite a bit of their time, not only to put on the presentation, but also to write it. So it's really useful for them to have some feedback to let them know kind of what was useful for yourself, but also if there are any areas that they can work on for their teaching. Only other thing that I wanted to say before we head off is that we do have 2 more webinars this week, both at the same time. If you found this event through the Facebook group, the links to registration are there in the event description. Okay. Any other questions before we go? Okay, well, thank you very much, and enjoy your evening, everyone.
Brilliant. Thank you very much.